All right, I think we'll get started. I'm Tom Bleck, and I have the honor of moderating this session. Moderator's the thing that captures all the excess neutrons in an atomic reactor, so I'll be catching your neutrons at the end of the presentations for so-called question and answer period. I'm going to tell you a little bit about each of the speakers to start with, and then they will just come up in sequence here. So we're going to start with the inventor of the system, Dr. Josef Parvizi, who's going to talk about AI in the system. He and I have argued this point for many years. I said he should call it machine learning, but he's given in to the current craze for everything being AI. He'll be followed by Dr. Chitra Venkatasubramanian, who is at Stanford and is a neurocritical care specialist, talking about clinical outcomes in point-of-care EEG. And finally, Mary Kay Bader, a clinical nurse specialist who is an old long-term friend of mine and a former president of the society. And she'll talk about integrating point-of-care EEG with AI into practice. So without further ado.
I am going to talk about three most obvious things. So you're not going to learn anything new. The first and foremost is the discussion in medicine, not just neurocritical care, but in the practice of medicine, and not only in the United States, but elsewhere, is really the problem and friction between those who are pragmatic versus those who are conventionalist. Many decades ago, a bunch of people got together to fix a big problem. The problem was that those days they were having amplifiers that could allow up till 16, perhaps at the most 32 pen and paper type of EEG. Johns Hopkins was doing certain number of electrodes. They were placing it somewhere, and Chicago, Iowa, everyone was doing it in their idiosyncratic way. So they couldn't do any standardized EEG research. And that is why they got together with the visionary Herbert Jasper on the lead, deciding to put these electrodes in the right place so that everybody can interpret everybody's EEG. That was the only reason to come up with full montage EEG. And they decided to measure it very carefully on every single patient. They had time. This was 1950s. Labor was not that expensive. They could hire as many techs they wanted. And there wasn't that much EEG, and there was no mention of point-of-care EEG. And that is the only reason they decided to put it full montage, to standardize it. Why did they decide so many electrodes? Well, because they wanted to cover the whole head. At that time, there was absolutely no information how many electrodes you need, especially in neurocritical setting. So they said, well, it makes sense to cover the whole head. That was the matter of convention. It wasn't a matter of science. It wasn't just because you have to have full montage in every single setting that they decided to come with 1020. This was just by convention. And if any of you guys over here sit down and said, well, we must have full montage, you by definition are not remembering that you are becoming a conventionalist. You are not really following the science. Because if you really look at the evidence, one after the other has shown that seizures that are very focal, only seen in parasagittal and midline in adult non-neonatal populations, they are less than 1%. So you are forcing your team to do full montage, very bulky. Yes, it looks fancy, but you're forcing your team to do something impractical, and you're not being pragmatic. You're not really taking into account the setting in which point of care has to be performed. It is 2 a.m. The resident or the intern, poor person, has to actually run from one code stroke to another trauma, and you're asking them to basically deal with a concoction that has full montage just because your convention dictates that we must have full montage. Evidence says otherwise. So at Ceribell, we try to kind of think out of the box. We try to kind of question, do we really need full montage? We decided absolutely not, especially in the setting in the emergency department and in the ICU. And many cases of pathological conditions in the ICU can be identified with this reduced montage. And by the way, we decided 8-channel because 8-channel is the minimum number of electrodes that is reimbursable. Otherwise, you actually don't even need 8 channels. You can live with less channels. So we believe that simplicity matters, and we invite you to think very critically when you're assessing one vendor versus another vendor, one technology versus another technology. Please come out of your habitual conventionalist thinking. This is a real case. A person comes, code stroke, aphasic. They do all sorts of imaging. Nothing is shown, perhaps a little bit of hyperintensity or DWI abnormality on the left hemisphere. They slap Ceribell, takes 2 minutes. The answer is in front of them. So you actually don't need to spend 30 minutes to do a full montage because in 1950, somebody said you need full montage. That's number one obvious thing that I had to say, that there is a lot of conventionalism in the practice of medicine, and I invite you to be insightful about that problem and get yourself out of that habitual thinking. So be pragmatic, please. The second thing I'm going to talk about, which is quite obvious, is when you are trying to compare the performance of an AI algorithm, you need to have a reference. What are you comparing it against? We are comparing human expert readers with AI. But guess what? Humans are not reliable because there is a huge inter-rater variability, especially when it comes to ictal-interictal continuum. So EEG is not just black and white, especially in the ICU setting. We are not talking about epilepsy monitoring unit. We are not talking about outpatient EEG. We are talking about people who are critically ill. You have vast amount of pathological abnormalities that are intermixed together, and now you are trying to make sense of it from the scalp. This is an average signal, very high dimensional, and if you give it to EEG readers, as you see over here, there is quite a lot of inter-rater variability, but the good news is that AI will always remain at highest about 80 to 90 percentile. So when you're comparing the AI to human readers, please consider that the gold standard is actually not gold as you thought. Gold standard varies depending on who you are taking. And we have a couple of publications that are coming out, which is really interesting. FDA asks you to have majority consensus as your gold standard. And companies that want to actually prove their algorithms, they compare it to the so-called majority consensus, which is 2/3 majority. And if you want to save money, you just hire 3 experts, and then you use 2/3 majority as the gold standard. What we did at Ceribell, which you don't see the data here, but we took 8 experts, and then we shuffled who is the how many of them, the 3 of them we shuffled. So of 8, we made quite different number of 3 experts. And then we looked at 2/3 majority, and if you actually plot the distribution of the so-called truth, it's quite scary. So there is a wide array of discordance, especially when it comes to ictal-interictal continuum. So the gold standard is shaky. That is the second obvious thing that I had to say. And the third one that I'd like to close with is that AI is constantly improving. So if you are trying to assess a technology, an AI algorithm, do not rely on literature from 10 years ago, because that is no longer the same AI. Right now at Ceribell, we have about over 1 million hours of EEG, over 200,000 patients' data, and our team of R&Ds in-house, we are working on ICU data and ED data, and those data are captured with our own hardware. You cannot ignore the importance of doing this type of development. So the way that we designed this Clarity algorithm, for those of you who don't know, is very unlike the other algorithms for seizure detection, because we think in the ICU and in the neurocritical care, the problem is not just one tree falling, but whether or not there is a major fire in the forest or you are seeing signs of smoke. And for that reason, we take 5 minutes of the EEG and review every page of the EEG. So the algorithm reviews 300 seconds of EEG in 10-second windows and determines, it's not a probabilistic algorithm, but deterministic, defines how many of these windows contain seizure activity and calls it. It's either 0 or 1. And then after 10 seconds, it rolls it forward, and that way it gives you a line basically depicting how the seizure load is going up or going down. Whenever it comes to 90%, it starts alarming. That means 90% of the last 5 minutes was seizure. And because ACNS keeps changing the standards for what is status, what is not status, we have become almost like psychiatrists, right? DSM-4, DSM-4B, and then so on and so on and so on. That is why we have now incorporated their new guideline. Basically, if 20% of the last hour is seizure or seizure-like, then it calls it status epilepticus. And the good news is that the performance is getting better and better, and we are confident that it is helpful in the setting of neurocritical care. As Dr. Al-Sharbini said, you can't just turn ICU doctors into EEG techs. You can't turn ED physicians into EEG techs. Problem is not access to EEG itself. Problem is access to actionable information at the bedside so that you can guide your decision making. And that is how Ceribell differentiates itself. So I want to basically tell you that in at least 6 domains, we have been trying to put a lot of weight in getting better. One of them is that we are truthful to the notion of simplicity. Number 2 is really the idea that when you are trying to assess the performance of an algorithm, please just don't trust the salesman, what the salesman is telling you. Look at the literature. Is there any proof in the literature? Has it been vetted? Has it been reviewed, etc.? Third one is that we have this portal. We can actually let you use your iPhone or iPad without going through the security firewalls of your hospital. Although we have a very secure system, we just got the highest grade cybersecurity from government, and that's why they are expanding to all VA hospitals in the United States and military hospitals. So cybersecurity is a big thing for us to focus on. And we have been doing 4 clinical trials so far. We are supporting NIH. We are giving money to investigators to do their research. So that's always been part of the culture at Ceribell, and we'll continue it. And we have a nice 1-800 number. And what else am I supposed to say? Well, now money counts. So we have been successful in terms of convincing the administrators that Ceribell pays for itself and it saves money. And in fact, point of care saves money for your hospital and for your system, and it helps the patient care. So with that note, I really personally, on behalf of Ceribell, on behalf of 280 plus people that work for the company, I thank you for all of you who have been using the device and giving us feedback. We really appreciate it. So on the portal, if you are a Ceribell user, there is a thumbs up thumbs down function. If you disagree with the read of AI, please press thumbs down because it goes directly to the office of CTO and these files get compiled and we retrain the AI and that's how we get better. So please give us feedback, please help us, and thank you very much for being here.
Thanks, Josef, for setting the stage about the clinical data. So I'm a clinician at heart. I work with Josef at Stanford, and I'm going to take the next 10 minutes to talk about some of the recent publications that have come out from Ceribell, maybe comparing rapid EEG, Ceribell EEG to conventional EEG. So this one was published in Neurology in 2024. It forms Class 2 evidence for seizure assessment and forecasting with rapid EEG compared to conventional EEG. So the way this study was designed, or the intent behind this, is we know that continuous EEG or conventional EEG is a very precious resource, is a very scarce resource, not available everywhere. And so we want to detect and place it appropriately on patients who need conventional EEG or long-term monitoring. And one of the ways to do that was to use a 2 helps to be score on the first hour of conventional EEG as a seizure prediction and a forecasting tool. And for those of you that are not familiar with the 2 helps to be score, it includes clinical, it includes electrographic markers on it, gives you a score. And if the score, for example, is 0, it's low risk for seizure. This is calculated over the first hour and the seizure prediction over the next 72 hours. If the score is 1, then it's a moderate risk. And if it's more than 1, it's a high risk. So it helps to kind of triage the patients that are at high risk of having seizures in the next 72 hours. So doing the same thing with rapid EEG in the first hour. So this retrospective study was a multi-center study from 4 academic institutions of over 900 or close to 900 adult patients over a 4-year period. You can see that there are 240 Ceribell EEGs and 650 conventional EEGs. And the 4 locations were University of New Mexico, University of Wisconsin-Madison, Mass General, and Yale. And the intent was to show that the rapid response of Ceribell EEG was non-inferior to conventional EEG when you used the 2 helps to be score as a seizure forecasting and predicting tool, and that primary outcome was achieved. What you also see here is that when you compare the areas under the curve for both the conventional and for Ceribell EEGs, they all overlap. So again, going to show that it's non-inferior. So you can use rapid EEG with the same confidence as a conventional EEG for initially seizure risk triage, figure out which are the patients that are going to need prolonged monitoring, need continuous monitoring, which are the patients that are at higher risk of having seizures in the next 72 hours. The false negative rate is very similar with both, about 2% with both Ceribell and with conventional EEG, and the seizure yield is about very similar, again, 9 to 10% for both modalities. This one was a sub-study of the SAFER EEG clinical study, and this data was presented, I believe, at the Lund Symposium last year as well. What this sub-study looked at is for the 3 sites that had access to both rapid EEG and conventional EEG, and looking to see what happened to the key clinical outcomes of patients who got rapid EEG versus those who got continuous EEG. Now, one might say, well, there's variability based on the physicians, why you're pacing a rapid EEG versus continuous EEG. Maybe it's like after hours, maybe it is a weekend, maybe these patients are thought to be sicker than the others. So a lot of propensity matching was done to look at this. And on the matched cohort, you have 62 patients in each, so conventional 62, Ceribell 62. The matching was done for a variety of clinical factors, and other factors are known to influence outcomes. And what we see from this is the median ICU length of stay was substantially decreased in patients who got rapid EEG as your first EEG monitor. So 4.1 days reduction in ICU length of stay. And that is huge for anybody, for any healthcare system. The functional outcomes of patients who also had continuous EEG were less optimal than those who got rapid EEG. And finally, the access to EEG from when they hit the door, so similar to what we do in strokes, so time to CT, so similar to that, like door to EEG metric was substantially faster for the Ceribell cohort compared to the conventional EEG cohort. Now, Dr. Bleck was there at the symposium last year, and he asked a question. And he said, like, okay, that's all great, but what is the driver for this? Have you all looked into what the driver for this improvement in length of stay is? And this particular study did not address it, so a shameless plug for our poster 244. Come and look at it this afternoon. So where we show what the driver for this reduced length of stay is. And you can all take a guess. And if you don't guess, come to the poster and see it. The Accurate study was also published in Neurology earlier this year. This again provides level 2 evidence to support a practical adoption of rapid EEG with the Clarity in different sort of work or hospital systems or settings where there's availability of continuous EEG, there's an expert, there's no continuous EEG, you're in a position to transfer and so on. So this one looked at EEGs from the Yale Health System, so 3 hospitals, so the academic hospital, the community center, and inner city associated with the Yale system. So 235 EEGs. These were all reviewed by several expert EEGers, and it was compared to the Clarity version 6.0. So Clarity is now at version 8.0, so this was the Clarity version 6.0, run on the same EEGs and compared to see what the sensitivity, specificity, positive and negative predictive value was. So setting the seizure burden threshold at 10% or less. So the what you can see up there on the slide is Clarity version 6.0 detected electrographic status epilepticus or possible electrographic status epilepticus with 88% sensitivity and a very, very high negative predictive value. When the seizure burden is set at 90% and above, again, the detection, the specificity, the positive predictive value are extraordinarily high. So you can be quite confident when the seizure burden output that is displayed on the device is less than 10%, you can be pretty darn sure that these patients, you're not missing status, you're not missing electrographic status. These are usually normal or slow EEGs. On the other hand, when it's like 90% above, you can be pretty darn sure that these patients are in status and you're not causing like a false alarm. Again, based on clinical factors, decide if you need to make these patients on continuous EEG and monitor them for a longer period of time. The final paper that I want to talk about is published at AAN, was presented as an abstract earlier this year, again confirming what we've all known for a very long period of time. The prior data all came from continuous EEGs, where it's been shown repeatedly over the last several decades that if you are an electrographic status epilepticus, that is associated with worse outcomes. The same was shown with rapid EEGs from the SAFER EEG study. So of the 300 plus EEGs where the ACNS criteria was applied to call this as electrographic status or not, 10% of patients from that cohort met the definition from ACNS of electrographic status. After matching for a variety of confounders, patients who were in electrographic status ended up having worse outcomes, functional outcomes, and this again mirrors what we already know from continuous EEG recordings. So I'll turn it over to Mary Kay to talk about how she's implemented it at our hospital.
Thank you, Chitra. So a little bit of perspective. I come from a community hospital in Orange County, California, and I'm going to give you the perspective of a bedside nurse. And I'm a clinical nurse specialist, so my office sits right in the middle of the ICU. I'm daily running in and out of rooms from one place to another, interacting with our nurses. So there has been some explanation on the simplicity of applying this headband EEG system. Now, the one thing I want to say is that if you look at the cover, This is genius. Because, why, you may think, why is she saying that? It's the inside cover. Well, I don't know about your staffing, your ICU turnover, how many nurses have come in, how many nurses have left. No one goes to a policy and procedure manual in the middle of the night to look to see how to apply the device that you have now ordered, right? So I have registry nurses, I have brand new nurses, and to be able to say to them when the neurointensivists say, I want you to apply the headband EEG device because our EEG tech's not available, they're not in-house at nighttime, and they can literally open the cover and just follow the directions and apply it in 3 to 4 minutes. That is a big deal. And it really does help. We do annual skills testing and competency testing, but the turnover is significant. And so you have a lot of nurses. When we deployed this system in 2018, so we've been using it for 7 years, we made a conscious choice to place it in 7 different clinical areas. The emergency department, both ICUs, the stroke unit, the step-down ICU, as well as I put one in the hands of our rapid response team because they go to all the concerned staff, nurses, situations outside of critical care, also supporting the emergency department. So we give them the ability through a standardized procedure to deploy it. The other thing that is advantageous in this system, because it is disposable, is there's less infection risk and cross-contamination because this is a disposable system. The headband is disposable. And so they don't have to be concerned about cleaning anything afterwards. If you have, like at one time, a few months ago, we had 5 patients with the headband EEGs running that had, between 4 p.m. the night before and 8 a.m. the next day, there were 5 different patients in different clinical areas with the devices on. Now, if I had only a couple or was limited to how many non-disposable components, that would kind of be a challenge. And there is risk for infection. So it is the beauty of the system is that it's simple to apply in 3 to 5 minutes. They have to put a few points, medical record number, date of birth, their name, you put the answer a couple questions, you hit the record button, and the data starts to flow. The point-of-care EEG protocol at our hospital is pretty simplistic. It describes any patient who is comatose following return to spontaneous circulation after cardiac arrest. We generally deploy this within 30 minutes of ROSC in the emergency department. So we start with our EEG monitoring as soon as possible. Recent clinical seizure without return to neurologic baseline, unexplained episodic or repetitive movements that concern the clinical team, unexplained or persistent altered mental status. This is a huge one for the emergency department. The emergency department gets a lot of patients who come in with altered mental status. Patient may have been found down. Maybe it was a suspected stroke. It's part of their differential diagnosis. As simple as getting a blood glucose or a CT scan, it is one of those elements that the emergency department team will consider. And then patients with possible psychogenic pseudo-seizures. So it is deployed in the emergency department, in the critical care units. I would tell you that 2/3 of the use is after hours, what we call after hours, 4 p.m. to 7 a.m., when there are no EEG techs in-house. But there's still a number that are deployed during the day. In the emergency department, it's 24/7, the headband EEG, because we don't have the EEG techs come into the emergency department to deploy the full array for continuous EEG. Now, the empowerment of nurses at the bedside, this really does help with informed clinical decision. Nurses assess and monitor, right? No matter what. If I give a pain medicine, I have to go back 15, 30 minutes later and ask the patient, what's your pain level? If I'm giving a medication that the provider has ordered, maybe it's levetiracetam, maybe it's valproate, whatever the drug is, I can, with this device, go in and assess the efficacy. How is that drug working? Did the seizure burden go down? 15, 30 minutes later, an hour later, has it gone back up? I can report that to the providers to say, you know what, it went down to 0%. I'm an hour and a half later, I'm back, the patient's back at 80 to 90%. So it does enable the nurse to monitor the effects of the medications that they're given, as well as their clinical exam, et cetera. If it's increasing over 50%, we have the nurse talk to the provider, alert them, it's up over 50%. We're concerned about it. We're going to continue to monitor. At 90%, the provider's ordering medications to treat that level. And then in the comatose post-cardiac arrest patients, we know that's a recommendation from the American Heart Association in comatose patients to deploy EEG monitoring. So it enables us to start it, and then it's a bridge device. We're able to then switch them to full montage EEG. Our protocol has gone through many updates and revisions, and we listen to our nurses and the feedback of our team. There is a load on patients as far as nursing interventions, especially when we first started. We did 2 hours screenings, and we'd say every 15 minutes for 2 hours. You need to go in as a nurse, you need to assess your patient, you need to look at seizure burden. Well, if it's 0% and they're busy and they have a lot of patients, that takes a lot of time. So over the last year, we've done some remodeling and revision of our protocol. So if that device is deployed, they check every 15 minutes for the first hour. If the seizure burden is under 20%, then we say recheck it in an hour. Now, if it's over 20%, we have them continue the Q15 minutes for an hour. And then at that 2-hour time period, based on the Glasgow Coma Score and the clinical exam, the pupillometry, why is that included? This is not just a device that hangs there out there, and you're not going to make a decision based on just one data point. There are many aspects of care that you have to consider for the patient. The provider is going to decide whether they want to continue with EEG monitoring or not. And we've tried to reduce the amount of work for the nurses, but at the same time, keep up our surveillance in the patients. Now, an actual case study, this is a 68-year-old female who presented to the emergency department, this was earlier this year, with a primary medical history of stage 3 primary peritoneal cancer with a metastatic brain tumor removed 3 months ago. 1 hour prior to arrival, she experienced aphasia with difficulty following instructions. Her NIH stroke scale was 8. As you can see on the diagnostics on the slide, her CT scan, non-contrast was negative, CTA was perfect, there was no perfusion deficits. So what we have is we have a patient who had a stroke. Stroke is ruled out, right? So what's the next step? Well, the emergency department physician, the neurologist who happened, the stroke neurologist on call that night was our epileptologist. So they discussed about this isolated aphasia. They made the decision to apply a point-of-care EEG. And what you have on the slide is the EEG and then the seizure burden line at the very bottom. And you can see that that seizure burden line shows that the patient was experiencing a significant amount of non-convulsive status located in this one clinical area affecting language and communication. So as you can see on the slide, she received a number of different medications. By the time she was admitted to our stroke unit, we had broken the non-convulsive status. She was discharged home 20 hours later. So we avoided an ICU admission, and we also were able to get her home within 24 hours of clinical presentation. We also had a publication this year in the Journal of Stroke and Cerebrovascular Disease that looked at some of our data from the year of 2020, where 319 patients had a point-of-care EEG, and of those, 70 patients who were undergoing stroke evaluation and point-of-care were examined to look at the characteristics of clinical presentation. So you can see the characteristics of those with a stroke diagnosis versus stroke mimics, altered mental status was more common in stroke mimics, aphasia present in both groups. And as they broke the data down and took a look at the presence of seizures or non-convulsive status, they found that 16% had ictal or highly epileptiform activity in patients with acute stroke diagnosis, and 34% of those patients with stroke mimics. So seizure was the most common stroke mimic. It identified 2 patients with persistent expressive aphasia found to have focal seizures of the left hemisphere. And so they were also able to rule out non-convulsive seizures in the remaining patients without confirmed stroke on neuroimaging. So it has been, again, in that differential diagnosis, very helpful. Now, just a little snapshot of our use over the last 7 years. So you can see the usage has grown. Our emergency department accounts for about 50% of that usage. And so it means that we're deploying this technology earlier, enabling us to help make better diagnosis and give appropriate medications as well as disposition. So with that, I'm going to turn things over back to Dr. Bleck so we can answer your questions.
Okay, well, while the speakers are joining us here, I wanted to just make a couple points. The first one is, if you think you know why somebody is comatose, that doesn't mean they're not in non-convulsive status. And I commonly see this when I consult in the other intensive care units. We put the EEG on, and a few of them are in non-convulsive status, and there was no way to know that without the EEG. So this would be perhaps a way to do that kind of screening. The other thing is I occasionally hear, well, the patient was transferred over because Ceribell said they were in status, and when I looked at the EEG, they weren't in status. But you have to remember what that American Clinical Neurophysiology Society guideline for electrographic status actually meant. So we often think there's status, well, there's going to be a seizure, post-ictal slowing, a seizure, post-ictal slowing, but the ACNS criterion is designed to say more than 20% of that hour is ictal activity, that constitutes status. Well, where did that come from? It's a pediatric study that looked at the outcome of patients who had more or less than 20% of the time of that hour spent with electrographic activity showed their outcome was worse. So we could argue whether that's something that we would all want to call status or not, but what the algorithm, I believe, is doing is following the ACNS recommendations. Does that mean that everybody who's got more than 20% epileptiform activity in an hour needs anti-seizure medicines? I don't think that's ever been shown. But you should be aware that there's perhaps a difference of opinion about what might constitute treatable electrographic status. I don't know if any of the speakers want to address that.
Tom, I also want to mention that on the portal there's a thumbs up, thumbs down function, and it's a fun fact. In many cases, we see the local neurologist disagrees with the AI. What we do, we don't really it goes to CTO's office, but the CTO doesn't necessarily ask the algorithm to change itself just because of one neurologist. We send it to 2 more epileptologists. And often epileptologists, we see how they disagree with the local neurologist, because sometimes local neurologist actually, as you said, is not fully aware of the guidelines and so on, what constitutes status. So that's right.
Okay, questions? Yes, sir.
So the question is, do we provide feedback in a very polite way? Because it's very difficult for a company to go back and say, my algorithm is better than your 20 years experience. We say, would you mind if we connect to a epileptologist with you to discuss the EEG? That's the feedback. So if you have gotten any emails like that, that means something.
What is the maximum duration that this Ceribell can stay on and still be accurate?
Yeah, and I think it's important to make sure that the bedside nursing understands to check the electrodes. On the display, you'll see it's green or red. Make sure that the electrodes are checked. If gel needs to be injected, then use it. So that is all dependent on it, but up to 24 hours.
You have data that this can obviate the need for EEG techs at night completely?
Yes, we do have data. Happy to share that. More data is coming in terms of publications. It's very important to note that this is meant to be a friend of nurses, and nurses need to be friends with the device. It empowers them, as Mary Kay so nicely said, but the device performance depends on nurses to work with the device, because every 60 seconds, the device sends electrical pulses through all electrodes and check its sanity. If one of the electrodes is compromised, it sends a message on the screen with the map. This electrode needs to be fixed.
Yes, sir.
I think we're all aware that in modern society there's a lot of anxiety amongst white-collar workers that AI will replace them. So how have you dealt with that amongst epileptologists?
I think, nobody can really predict the future, but I think we're going to end up having more people who have seizures that we didn't detect before by using the technology, which is going to end up being more work for epileptologists and neurointensivists, but so be it. It's better for our patients.
And when it comes to EEG techs, what we have experienced in hospitals where they have adopted it, they don't get rid of their EEG techs. They deploy them into more intelligent work. For example, in epilepsy monitoring unit, labeling the EEGs overnight so the doctor coming the next day has the EEG well read by a technician, or they sent their EEG text to IOM and other places, or even outpatient. We have an account that actually changed their inpatient setting to outpatient. 2 of their EEG texts were sent to outpatient. Their volume of outpatient EEG went up, wait time went down. They got a lot of money for those EEGs in outpatient. They didn't get rid of any of their EEG texts.
Okay, our last question.
I want to hear more about experiences with like hemicraniectomies and then placing at the Ceribell, or just kind of like practical take-home points.
So we have deployed it in there. We just asked the nurse to make sure that when they're positioning the headband, that it's not, that you're not putting one of the things right over where the incision lines are. But we have used it. We don't use it for a long period of time. It's just a route.
We don't. As much as possible, if somebody's had a cranie or another reason why there might be skin breakdown, we have stayed away from using it. So sort of depends.
But it's only if the EEG tech's not available.
Right.
All right, well, we've used up our time and a little bit more, so I want to thank you all for coming, and the speakers will be here for a little bit if you have more questions. Thanks.
Thank you.